Dear audience, I would like to present my PhD topic, which is the investigation of the link between different diseases from the aspect of the oral microbiome. My name is Zsuzsanna Domokos from the Department of Community Dentistry. My vision is to develop an interdisciplinary knowledge by investigating the association between dental and systematic diseases and also improve the treatment which involves both dentists and medical doctors. My mission is to incorporate multidisciplinary attitude into clinical practice based on a comprehensive knowledge. My specific goals in order to fulfill my vision and mission is to identify a possible risk population in dentistry through a meta-analysis, and I would also like to improve the treatment and the follow-up method of periodontal patients. The title of my first meta-analysis is the investigation of the association between different multifactorial diseases, periodontal disease, and inflammatory bowel diseases. I have finished the writing of the first version of my manuscript. I have sent it to my supervisor, and we are planning to send it out for internal review next week. According to different epidemiological studies, periodontitis is the most common oral condition in the world. Some kind of periodontal disease can affect 20 to 50% of the adult population in the world. However, which is more important, severe periodontal disease can affect 10% of the adult population, which is the major cause for tooth loss. Moreover, periodontitis is not only an oral condition, but it can cause also some systematic diseases like coronary heart disease, preterm birth, or even stroke, which can cause the death of the patients. It is also known that there are several risk factors which contribute in developing periodontitis. Some of the best known are poor oral hygiene and smoking, but it is also known that there are systematic diseases which contribute in developing periodontitis, like diabetes mellitus and hematologic disorders. And our question, if maybe inflammatory bowel diseases could also be a risk factor for developing IBD, and also the other way around, periodontitis can also be a risk factor for developing IBD. As both diseases are multifactorial, investigating this association between them could improve the interdisciplinary knowledge and also improve the treatment of these diseases. The aim of this study is to investigate the association between periodontitis and IBD from both directions, try to identify a possible risk population in dentistry, and also some common risk factors between them. The clinical question is the following, that is there an association between periodontitis and IBD? And as I have said, we would like to investigate it from both directions. That's why we formulated two PICO frameworks, which you can read on this slide. The clinical implication of the study is to identify risk population. Here you can see our search key, and the systematic search was done in October on 3D databases. Here is my flowchart of selection. After the selection, we had 14 eligible articles. As our primary outcome, we compared the odds of periodontitis in IBD patients and in non-IBD patients. On this slide, you can see the forest plot showing that the odds ratio is 2.65, which means that if the odds for developing periodontitis in the healthy population is 1, then it is 2.65 in the IBD population. This means that the IBD population has 2.65 times higher risk for developing periodontitis. The odds for developing periodontitis is 2.65 times higher. The conclusion of this evaluation is that IBD patients have a higher chance to develop periodontitis than healthy patients. We did this evaluation in subgroup analysis separately for Crohn's disease patients and also ulcerative colitis patients, which you can see on the following slides. On this slide, you can see the Crohn's disease patients compared with healthy patients. The odds ratio here is 2.22. And in the case of ulcerative colitis patients, the odds ratio is 3.52. The heterogeneity is very, very low in all three cases, and all odds ratio prove that IBD patients, also Crohn's disease patients, and ulcerative colitis patients have a higher risk for developing periodontitis. As secondary outcomes, we compared clinical periodontal outcomes in IBD patients and in healthy patients, but there were so many studies which did not use a standardized way to measure these clinical periodontal parameters. That's why we had only a low number of studies. And all the results showed statistically significant difference. However, these were not clinically relevant. The main strength of our study is that we investigated a clinically relevant question. According to the risk of bias assessment, which was done by the Newcastle-Ottawa scale, we had high-quality studies. This is the first study to investigate the association between IBD and periodontitis from both directions. We had a proper registration. We followed the Cochrane Handbook's recommendations. And the studies came from different countries, so we had a population from all over the world. Some of the limitations is that I have mentioned. We investigated from both directions, and for our second PECO B, we found only 2 eligible studies, so we could only put that into the systematic review part and could not do a statistical evaluation. The question suggests that no RCTs will be available, so although this is the highest quality of evidence that we can reach in this question, our results do not prove a cause-relationship association. And as I have said, the measurements were not always done in a standardized way, and we should emphasize the dentists always done the measurements in a standardized way so they can be compared in a meta-analysis in the future. The conclusion is that IBD patients have a higher chance to develop periodontitis than the healthy patients. And as an implication for practice, we should bring multidisciplinary attitude into the treatment of IBD patients. Both gastroenterologists and dentists should be aware of this association, and we should emphasize the importance of regular dental checkups and prevention in their case even more than in the healthy population. As an implication for research, we know that both diseases are multifactorial and the full pathogenesis is not fully understood. So investigating the association might help us find some common immunological or genetical pathways or some common behavioral and environmental risk factors which can help the treatment of these diseases. The title of our second topic is the association between matrix metalloproteinase 8 and clinical parameters in periodontitis. Periodontal diseases are destructive processes involving the periodontium, which is the supporting apparatus of a tooth. On this slide, you can see a picture of a healthy gingiva and also the clinical parameters. On the next slide, you can see a picture of a patient with gingivitis. The biggest difference that when probing, we get bleeding. Although the biggest difference compared to periodontitis, that in the case of gingivitis, there is no attachment loss, but in the case of periodontitis, there is also radiological and clinical attachment loss. Here, you can see the histology of the histological parameters of the healthy gingiva, but only after 4 days, there are histological differences in the gingiva. However, the clinical signs of the disease can be investigated only later. However, there is an enzyme, the matrix metalloproteinase 8, which elevates in this clinical stage, not only in the future. The matrix metalloproteinase 8 is a collagenolytic enzyme. It causes periodontal degeneration, and in active periodontal tissues, the pathological elevation and the activation of MMP8 can be measured. These are reflected in the gingival curvicular fluid, which is the most important, but most measurements measure it from the saliva because it gets into the saliva. The aim of this study is to compare how the level of activated MMP8 changes in the periodontally healthy patients and in patients with periodontitis. And we would also like to compare the reliability of MMP8 level measurement with conventional clinical and radiological diagnosis of periodontitis. The clinical questions are the following. Is measuring the level of activated MMP8 is a reliable method to diagnose periodontitis? And is it an appropriate tool for long-term follow-up of periodontal patients? You can see the PICO, which we will use, and the hypothesis on this slide. The clinical implication of this study is try to use a novel, simple, and convenient method to diagnose and follow the clinical stage of periodontal patients. Here you can see the search key which we used. The search was done on May. And right now we have finished the Prosper registration. And I would like to thank you for your attention with their following quote: "Every mountaintop is within reach if you just keep climbing."
Thank you very much for the presentation. If I may ask you to go back to your first forest plot for your first project. Okay, so here you have almost 1,000 people, and one of the strengths of your review is that you have patients from all over the world. but your heterogeneity is 0%. Yes. So obviously something happened in the mathematical analysis here. And the question is, the conclusion that you're drawing is very critical. I mean, it is absolutely interesting for everyone involved in these fields. However, how much do you think with this heterogeneity problem, how much do you think is the generalizability of this conclusion? Because on the other hand, aside from the mathematical analysis, your PICO includes all healthy patients. There is no age restriction. So all of these people are probably different ages. They are usually diagnosed in adulthood. So maybe this is also introducing a lot of different diseases. And at the same time, you're also not making any distinction between ulcerative colitis and Crohn's. So what does this say about the generalizability of your conclusion?
Thank you for your comment. I think the heterogeneity and the population from all over the world comes from the eligibility criteria because it's very similar in every case. You have mentioned also the age difference. All of the studies used adult patients, and the mean age was around 40 years in every case. This was not an eligibility criteria, but most of the studies choose IBD patients, and the mean age is around 40 years, and they choose comparison to match these IBD patients. So in all cases, these were very similar. So that might cause that the heterogeneity is very low. So it can be generalized. And you have mentioned that there is a different evaluation both for Crohn's disease and also for ulcerative colitis separately, and you can see that there is a difference between the odds ratios in their cases. I hope I could answer your questions.
I just want to reflect to one thing, that if you go back to this figure, I want to highlight the fact that one study has at least 2 times greater weight than the second one, and the others are much less. And this could reflect how heterogeneity works a bit. So I think this is what happened in the background. My question, on the other hand, is that for your last topic, I've only seen data for 2 databases. Have you used all 3 databases, what you've mentioned?
We will use the MBase also. We have the Prosper registration, but have not registered it yet, so it's a draft. So we will do it in the following days, yes. We will use the MBase also.
Congratulations for your presentation. I just wanted to know how is the MMP8 level measurement is going to be done if you're taken from different locations, methods, and how are you going to address this in your topic?
Thank you for your question. It's a great question. According to different studies, most of the studies, there are 2 types of studies. One of them uses laboratory measurement technique, and there are also chair-side techniques. So we will definitely make subgroups based on the measuring a laboratory or chair-side techniques because they make a huge difference. They cannot be compared to each other. Thank you.